Good evening, everyone. Welcome to today's live uh, webinar show on Boneflix Denosumab Talk Show. The topic for today's webinar is Unveiling the Curtain, the evidence of Denosumab and its impact on the fracture risk. So, for today's session, I am honored to welcome Dr. Vinay Agrawal as a speaker for today's program. And Dr. Also, I welcome Dr. Nitin Kapoor as a host for today's program. So Dr. Vinay Agrawal has a vast experience in this field, who has managing such kind of condition uh, in the daily practices and is currently working in Ultimis Hospital, New Delhi. And Dr. Nitin Kapoor is currently working in CMC Vellore, Tamil Nadu. So I hand over session to Dr. Nitin Kapoor. Over to you, sir.
Thank you, Dr. Nishikant. And I think it's a great privilege and honor to be on this platform. I think we need more and more such sessions where we cross talk between specialties, orthopedics and endocrinology. We do a lot of common work, but I think talking to each other, we learn from each other, but we also educate all the audience and the viewers who've also joined us today. And it's my privilege to welcome Dr. Vinay Kumar Agarwal, currently the head of the Department of Orthopedics at the Artemis Hospital, New Delhi. Dr. Vinay has a very illustrious career, just going through his CV right from early days from prestigious colleges from MAMC in Delhi to Safdarjung, and a very good stint in the UK as well, and has been working with the NHS up to 2016, and thereafter several hospitals in India, and one of the renowned orthopedicians that we have today in our country, managing both orthopedics and sports medicine. And today we are talking about molecule Denosumab, which is helpful for treating osteoporosis. So just before we start, Dr. Vinay, I thought I'll just give a very brief 2-minute introduction for all the audience who've joined us. How important this topic is when we talk of osteoporosis today. When we look at data, whether it's from North, West, East, or South India, including data from our center, what we find is that about 50% of postmenopausal women in India have osteoporosis. So that's huge, but even men are not spared. Men are probably just lagging a couple of years behind, but they also have osteoporosis. Maybe by the age of 60, another 50% of men also have osteoporosis. But what we are really worried about is a fragility fracture. And why we are worried about fragility fractures is something like a hip fracture that Dr. Vinay would manage sometimes is something which is lethal. Even in the best of countries, in the United States, the mortality of a hip fracture is 30%. 1 in 3 people who develop a fragility fracture of the hip joint would die within a year. So I think this is the importance of this particular topic, which is so common. It is possibly lethal, but the good thing is we really have very effective tools to kind of manage the osteoporosis, but also prevent these fractures and therefore manage this collectively. So warm welcome, Dr. Vinay. It's great to have you on board, and let's start our discussion today. But maybe before we get going, would you like to have some introductory comments about our webinar today?
Thank you, Dr. Shikant, and so much thanks to Nitin Kapoor for a wonderful introductory, this prologue, and thank you for inviting me on this very relevant and very current up-to-date topic. And as what Nitin Kapoor said, that it's very important that the specialities of specialty endocrine and orthopedics come together and sit down on this platform, because it's a challenge. You see, it's not a one specialty problem. It's a cross specialty problem. We are seeing patients coming from the various walks of life and presenting to different specialties. So we should have a shared opinion and a shared consensus among specialties as to how to approach this. I would say an epidemic of osteoporosis. Now, coming to osteoporosis as we define it, basically, osteoporosis is a condition where the bone is critically defined as loss in bone density. So basically, what happens in osteoporosis is that the bone matrix starts losing its strength. It's different from osteomalacia and rickets, which can happen with vitamin D deficiency. It's not just loss of bone mineral; it's a loss of bone matrix. So the bone the bone density comes down. The bone is still there, but the bone matrix become very sparse. And if you see an osteoporotic bones, if you see if someone managed to see an osteoporotic bone in histopathological specimens or in cadavers, the bone is much wider compared to a normal young person, because the cortical density goes down and the bone naturally adapts to become more wider to accommodate for the load, and that predisposes to being in low density predisposes to fragility fractures. And as Dr. Kapoor said, it's not just about fracture management. It's not just a normal fracture. The the studies have shown that there is a quite high mortality risk of people who sustain hip fractures, whether we manage them surgically and whether they keep go on to walk normally. But still, the 1 year to 2 year mortality rate is nearly as high as one third, as Dr. Kapoor said, 30%. So it's very important that osteoporosis is managed medically, and the bone density is controlled rather than managing the fractures.
Very well said. I think that's the highlight of today's session. And though we are going to talk a lot about osteoporosis, we are also talking about a molecule, Denosumab. And though it's primarily used for treatment of osteoporosis, but I'm sure in Dr. Vinay and my practice, we do use it for metastatic bone disease. We also use it for giant cell tumors, for other indications. And we'll touch about that. But I think the elephant in the room today is osteoporosis and how we are going to use this molecule for that, and how it is clinically helpful in our day-to-day practice. So I'm glad to hear that there are about 2,500 registrations for today's webinar, predominantly from the orthopedic domain, but we do have a lot of registrations from across the country and even beyond. So Dr. Vinay, let's start our discussion. And for our very naive audience, some of them who may not have used denosumab so far in their practice, how would you say is this molecule in terms of its mechanism of action? What is the basis behind its use? How does this molecule act on the bone?
So, Dr. Kapoor, first of all, I would like to classify treatment for osteoporosis based on simple two categories. One is anti-resorptive, that is anti-catabolic, and second is anabolic. So, osteoporosis is a condition where the bone turnover is quite high and the bone dissolution because of osteoclastic action is high, so that the bone formation is is superseded by bone dissolution. So the basic treatment of osteoporosis is, revolves around the fact that either we stop the bone resorption or we make bone formation. So there are two things in the market, two categories of treatment. One is anti-catabolic, in which we have denosumab, we have bisphosphonates, and we have estrogen and selective estrogen receptor modulators. And the second category of treatment is anabolic, where the treatment is aimed at promoting bone formation, in which comes the condition, the molecule called a teriparatide. Now, coming to the action of denosumab, denosumab was licensed for postmenopausal osteoporosis use in 2010 by US FDA through the Freedom trial. It is a monoclonal antibody of IgG, monoclonal human antibody, which attaches to the rank ligand of osteocytes. Now, the rank ligand, what does it do is that rank ligand is important for binding with rank proteins in the osteoclast, which activates the osteoclast. So, what the denosumab does is that it inhibits the rank ligand, and the rank ligand cannot bind with rank proteins and OPG proteins in the osteoclast. So, the osteoclasts do not get activated, and since the osteoclasts do not get activated, their function of bone dissolution, that is dissolving the bone, is impeded, and that's how denosumab works. It has an anti-resorptive function.
Very, very simply explained. Thank you, Dr. Vinay, for that answer. What we're trying to learn here is that yes, we could either reduce the resorption of the bone or make the bone stronger by using anabolic agents. Denosumab is an anti-resorptive, so it is reducing the resorption, reducing the osteoclastic activity. Very well said. Yes, it is something that was initially approved for postmenopausal osteoporosis. There have been other approvals later on, but in terms of efficacy, Dr. Vinay, now that you mentioned that we have these two broad categories and three big drugs that we use, bisphosphonates, PTH, and denosumab, how would you rate the efficacy of denosumab in terms of reducing fracture risk, especially when we compare it across the other drugs that are available?
So, Dr. Kapoor, if we compare the efficacy in terms of, I would say I would compare efficacy in terms of three broad categories, or rather three broad categories. One is vertebral fractures, one is hip fractures, and third category is non-vertebral fractures and non-hip fractures. So as we see, when we go for DEXA scan, we see there are three broad categories of scan. The report comes in. One is the scan of the forearm, that is non-vertebral area. One is a scan of the hip joint, and one is a scan of the vertebral fractures, vertebral area. So I would say that the studies are still keep on coming, and there is new and new advances which are happening. And though molecule was introduced in 2010, but Indian market was late to pick up, and then still there is a lot of lot of still we have a lot of scope of penetration of the denosumab into the Indian market. I would say denosumab has a strong effect in vertebral fractures. I've seen people coming with the T score of -4, -4.5, severe osteoporosis, and denosumab, the regimen described, that is 6 monthly injection, does show a strong effect, in terms of this vertebral fractures. Non-vertebral fractures like forearm, I would say still the effect is not that promising and that not that good. Those studies do claim, I would say, but in my clinical practice, I have seen a strong effect of denosumab in vertical fractures and some effect in hip fractures.
Absolutely. So a very similar experience here. And believe me, friends, for all the viewers who are watching us, I would say that many times patients come to the OPD with just low backache. Nobody has ever thought that they would have a spinal fracture. The only presenting symptom of that osteoporosis would be a small vertebral fracture, which they have sustained. They don't even know when they have sustained it. And this small fracture would beget another bigger fracture in future. And I would say this is a very big window of opportunity to see. And as Dr. Vinay said, this is a drug that works wonderfully well for spinal fractures. The pain resolves, the fracture prevention is much better. If I was to cap it to a number, I would say about 60 to 70% relative risk reduction of fracture. So 60 to 70% chance of reducing fracture is a huge number for any drug, for any chronic disease, I would say. So definitely very effective for spinal fractures, to some extent to the hip fracture. But Dr. Vinay, for all our audience, some of them again would be naive. Would you like to tell us, you did mention that it's once in 6 months. Would you tell us how much is the dose and how do we administer it? Which route do we use?
So denosumab comes in pre-filled syringes. Now we're thankful we have the good pharmaceutical companies and which are providing denosumab at much lower cost nowadays. The initial costing was to be very high. So it comes in pre-filled syringes. The doses are 60 mcg and 120 mcg. I usually prefer for post-menopausal osteoporosis. I would say I would go for 60 mcg as a routine, unless there is a strong, very solid indication for going for a higher dose. And we give it 6 monthly. Either the patient can self-administer, or we can take some help from the pharmaceutical person or in nursing. It's a simple injection which comes in a fixed dose. Normally the patient injects it like insulin in the subcutaneous fat of the abdomen, and once in 6 months is the recommended dose. The recommended initial dosage is 2 years. So I usually go for 2 years. In certain circumstances where we see that after stopping the denosumab, the bone density again starts falling, especially the vertebral, then I would restart denosumab. But initially I give a period of 2 years, that is 4 injections.
So that's directly from a clinical pearl, from a practice pearl, from Dr. Vinay's experience, and I completely concur with that. And I also see our audience who've joined us, and we have Dr. Manzoor Raina, who's talking about osteoporosis and talking about CKD, and I think that's a very relevant point in the comment section. I would say this is the only drug, I mean, of all the drugs that we have for osteoporosis, the only drug that is safe in people with renal disease for using for management of osteoporosis. So CKD osteodystrophy is a big topic. Probably we could cover it sometime again later on. But then I would say denosumab is the only drug. I cannot use bisphosphonates. I cannot use teriparatide in patients with CKD. And many times these patients before renal transplant, after renal transplant, or just on dialysis need bone protection. We don't want them to develop another fracture. So do you use, Dr. Vinay, this drug in CKD? What is your experience there?
So, Dr. Kapoor, for CKD patients, I would definitely refer to my endocrinologist colleague. I won't,
Correct.
I won't take it a second. I won't have a second thought that I would just start a drug. Being a surgeon, I have my own limitations. So I would
Yeah.
definitely consult my esteemed medical colleagues like you. But in principle, I do agree that this is a very. I mean, in the long-term safety data, if you see with denosumab, the data is very, very promising. The long-term safety is very high, and I would agree that in a CKD patient, this is the only drug. which we would, which we can reliably and confidently at least start, and to start off with to manage osteoporosis. But I would go by the advice of a medical colleague on that.
Absolutely. Thank you for that. And taking on to discuss this further, in clinical practice, many times when we start a new drug to a patient, the first question that will come up from the patient is, Doctor, iska koi side effect to nahi hai? I mean, they would really want to know that this drug is safe. And I would say always some drugs, most drugs would have some side effects. But what we're trying to do is weigh the benefits versus the risk. And so, what would you suggest to all our fellow physicians who've joined us, fellow orthopedicians who've joined us, as to what should they answer when the patient asks, Doctor, iska koi side effect hai? To what they have to tell?
So see, there is a side effect. I mean, there is no drug in this world which has no side effect, I would say. But I mean, as you rightly mentioned, the risk-benefit ratio is uh, strongly in favor of benefits. There are mild side effects which we sometimes encounter in clinical practice, like constipation, nausea, or sometimes initially, at the first injection. Sometimes these things can happen just with like any drug. But more importantly, I've on the later, in my later part of a practice, I've realized that sometimes with denosumab, the people who have been monitoring their PTH levels with denosumab, there is a transient rise in serum PTH level, and I have come across certain prescriptions of my esteemed colleagues who have stopped denosumab. No, with that transient rise in PTH. I would like to reassure them and tell them that rise in serum PTH level is a known thing with denosumab when you start denosumab treatment. And there is a transient rise in serum PTH, and that does not at all mean that patient is going to primary hyperparathyroidism or there is a bone dissolution going on. It is just a effect of denosumab. So there is no reason to stop denosumab if there is a rise in PTH transiently because that is expected of the drug. Secondly, in the long run, there is a very rare risk, I would say, of two conditions: osteonecrosis of jaw and atypical femur fractures. But the risk is much lesser compared to bisphosphonates. So, by and large, I would say the risk profile is quite low. But yes, when we are continuing the denosumab for a long-term treatment, we should tell the patient that there is a few side effects which they should be aware. And but the possibility is quite low. I would say the risk is 1:100,000 of having an osteonecrosis of jaw with denosumab treatment.
Absolutely. So definitely, again, I think the benefits outweigh the risk. Adding a few more side effects that you may inform your patient is about the injection site reaction that is common with everything. I mean, in my practice, I would use so much of insulin, and every injection could have that small injection site reaction, especially when you're using a monoclonal antibody. So, but that's just very minor, very easily manageable. Most patients won't have it, but that's something that you can say. The other thing for our physicians, I would say that sometimes it's helpful to monitor the calcium levels because the hypocalcemia that can be precipitated, especially if you have not treated that patient's vitamin D deficiency. So I think in addition to what Dr. Vinay said, maybe two additional points that I would add is the injection site reaction, and make sure your patient is well supplemented with vitamin D. We do not want any hypocalcemia to precipitate. Even if hypocalcemia precipitates as transient, it will get better, but then still nothing much to worry. But if you have depleted vitamin D, that is something that will take care of. But moving on with the side effects, Dr. Vinay, if I have another question for you, especially during COVID, when many of our patients could not come back for follow-up, they were on denosumab once in 6 months, and then suddenly everything was locked down. Some patients didn't come back for a year, especially in a place like Vellore, where most of my patients come from different parts of the country, and they wouldn't come for a year or two, and then people started missing their denosumab because the hospital phobia, going to the hospital, infection, COVID, all of that. So what is this so-called risk of rebound fracture when people discontinue? And already you mentioned it is important not to discontinue for the transient PTH rise, but what is the risk of rebound fracture on discontinuing and how we can prevent that?
Yeah, so Dr. Kapoor, these studies have shown that once the denosumab is stopped and you are not supplementing with either another kind of anti-osteoporotic treatment, and you just stop it, and as you said, rightly said, that COVID was a time when people just everything was helter skelter and people just had a phobia and they just stopped. So the graph starts coming down. You see the bone density, the whatever denosumab, whatever gains have been made, and especially if you've not taken the full, at least the standard course of 2 years, the graph coming down, especially, and that happens again, especially in the vertebral area. The vertebral fractures, the frac score starts going up, and the bone density comes down. We have sometimes seen that after completion of denosumab course, when we stop the treatment and we're not supplementing with any of the treatment, then the again the DEXA scan, if we get done, the T score starts rising up again, or coming, and they become more osteoporotic. So that again leads to risk of, yes, there is a risk of rebound fracture. I won't comment on the percentage, because there is no like a meta-analysis or a randomized study which has still been done, that how much would be the risk. But there is a risk of rebound fracture. So I would say that once the patient has been lost to follow-up, and if he does come for follow-up, it is advisable to restart the patient denosumab, and after getting a DEXA scan, and then follow up with a DEXA scan.
Sure. So I think that's a very important message, again, that Dr. Vinay is leaving us, that you do not stop denosumab abruptly. And when you are deciding to stop it, you continue another anti-resorptive or another anti-osteoporotic agent to follow up, so that the chance of losing the benefit that you've got with this drug is mitigated, so that you can give the patient not only the improvement with the drug, but you don't let that improvement go away in the future. So the important message is, do not stop abruptly. Always follow up with possibly another anti-resorptive. But we do have data now for almost 10 years. We can easily use denosumab. So it's not that just it's 1 year use, 2 year use. We can safely continue this drug, given the ease of convenience, which is just once in 6 months. I think this is really helpful. But Dr. Vinay, again, since most of our audience today is from the orthopedic fraternity, I'm sure a lot of people would ask you how this drug would be in terms of improving the outcomes of orthopedic procedures, how it helps in rehabilitation, how it helps in fracture healing after all the surgeries and the implants that you do, and what is the evidence so far, and what is the message for that for all our orthopedic colleagues on that.
So, Dr. Kapoor, there was latest NICE guidelines. So, I would say that what I in my practice follow as per the NICE guidelines NHS, is that any patient, any especially females, so let's talk about females first. Any patient who is above 50, postmenopausal female, who has had a fracture, I would say that, and which is osteoporotic fracture, which namely, vertebral fracture or a neck of femur fracture, intertrochanteric fracture, proximal humerus fracture. All these will, I would say, osteoporotic fracture, and also the Colles fracture of the wrist. So any patient who has these fractures, they should be followed. They should be started on anti-resorptive treatment, or some anti-osteoporotic treatment. One of them is denosumab, and I would follow them up on a yearly basis on a DEXA scan. And if at all these patients get operated, then obviously the anti-osteoporotic treatment has to continue. I would not be too much worried about having exactly T score of 2.5, that is the cutoff for osteoporosis, but because they have had a fragility fracture above the in their age group of postmenopausal, and then that's as per the NICE guideline, there is a good enough reason to start a yearly DEXA scan and continue them on anti-osteoporotic treatment. Any patient who does not have a fracture, who had never had a fracture, and suppose a DEXA scan shows a higher, a 2.5 or plus reading, 2 point, and then I am having to operate on that patient for another fracture, which may be traumatic, I would still go for anti-osteoporotic treatment. I also go for anti-osteoporotic treatment in athletes. You would be surprised that young athletes, but I've seen that sometimes athletes come up who have vague pains in the data. Pain is not settling down with anything. We have done surgery, we have done arthroscopy, but we see that this bone, this anti-osteoporotic treatment helps them to, kind of recover with pain. So yes, I do cover my orthopedic surgical procedures with some duration of anti-osteoporotic treatment, depending on the patient and the DEXA
Right.
scan.
Sure. So I think a very, very important message there. What Dr. Vinay is telling us, that even if patient has just got a fragility fracture, patient cannot do a DEXA scan. The indication for starting anti-resorptive is just presence of fragility fracture, irrespective of what the DEXA scan shows, because one fracture would get to another fracture in due course. A fragility fracture would be any fracture where a patient falls from a standing height, and a trauma which is not significant, or low trauma that causes a fracture. So, friends, the important message today is that any patient who's probably got a vertebral spine fracture, which is incidentally detected itself, is an indication to start anti-osteoporotic treatment. Yes, there is more and more data emerging whether this is going to be helpful after orthopedic procedures, but definitely for prevention, it is helpful. I think another important point that Dr. Vinay pointed out was repeating DEXA scans after a year, and that is minimum after a year, I would say. Many times, unfortunately, sometimes the DEXA scan is repeated too frequently. We must understand that bone is an organ that takes time for it to really improve. And with the kind of the technology that we have with DEXA scan, the minimal amount of change that we can detect over time would take at least 1 year for that change to happen. If you get a report within 6 months, it may not always. Exceptional circumstances are there where we talk of secondary osteoporosis where there's rapid improvement. But by and large, I think two important messages from what Dr. Vinay just answered. A fragility fracture itself is an indication for starting anti-osteoporotic treatment, and you need not need a DEXA scan for that. And minimum duration you wait for repeating a scan is 1 year. Yes, after orthopedic procedures and rehabilitation, more data is coming up, and in due course, we will have more exciting answers to this particular question. In the meantime, yes, we could use bone turnover markers, which are available now in India, and that help us decide whether this particular treatment is working or not working. So yes, that's important. So I think the audience is also keen to look at some real life experiences. You did mention about one of your patients who had -4 and how it improved. But you would like to share any other patient experiences with denosumab? What do patients come back and tell you once they are on this particular drug, Dr. Vinay?
So, Raghu, yeah, so most of the patients, as you said in your opening prologue, that obviously it's a more of a, it's a, it's not being sexist here, it's a gender bias here, with osteoporosis. Unfortunately, most of the patients are indeed females, and though males do get osteoporosis, but yes, it's I would say 70 to 80% patients are postmenopausal females, and with the kind of lifestyle and this with the fitness thing coming up, and if so age is no bar for fitness activities now. So we see that a lot of gymnasiums, everything, people, females, and males also more than 50 plus are doing all sorts of activities. So when we talk about this osteoporosis in females, obviously, when this is, I've had patients who had vague pains. People obviously sometimes patients do not actually present with with just a fracture. They just come with pain. There's like moaning. Like they just pain. The whole body is paining, and there is no answer why it's paining. So why what and we just come to the conclusion, it's a postmenopausal female, whether DEXA scan is even showing a normal T score, but pain is there. So we do sometimes start them on empirical grounds, on a clinical, on my clinical, I take the liberty of being a clinician, and sometimes without objectivity also, I do start them on anti-resorptive treatment or anti-osteoporotic treatment, and I find that they have a dramatic relief. Their lifestyle improves, their pain improves, they can more go to fitness activities, they are able to, they are more happier, and it does make a lot of difference in their self-esteem and their lifestyle. Secondly, one thing which I have noticed is that though DEXA scan is a good marker, but as I said in my previous this thing to question answer also again, that it has a strong effect on mainly vertebral and hip fractures. I have seen a lot of people coming with denosumab treatment who have not a much effect in this forearm fractures. The forearm part of DEXA scan, that is something which we just tend to notice. It's just my observation, and I don't know how much difference it makes, because that's the best we can do in terms of treatment. But that's just an observation that a lady who came to me with a DEXA scan of 4. I started denosumab. The hip DEXA scan came down to like 1.3. The spine DEXA scan report came down to like about 2, but the forearm DEXA scan actually got worsened. So I had just to counsel her that, just be continue your treatment, continue calcium, vitamin D, and maybe add some another maybe anabolic, agent on that, just to supplement it. But it's just an observation I would like to share that it is not much effective in non-vertebral fractures, non-vertebral DEXA scan reports.
Yes, and I completely agree with that. In our practice here in Vellore, where we run a special clinic for osteoporosis and metabolic bone disease, we do see very significant improvements in the vertebral BMD, but not in the others. Uh, there are questions where people are asking as to why we have we may start denosumab, even if we've just got a fragility fracture. And then what is the need to do DEXA scan? The need for doing DEXA scan is only so that you have a baseline value, so that when you start treatment, you know how well we are improving. So again, I will, underline and say that you can start treatment just in the presence of fragility fracture, but the help of the DEXA scan there is just to tell you that how this is going to improve with due course of treatment. You get some hint by reduction of the bone resorption markers like beta cross slabs, but doing a DEXA scan at follow up will be helpful. So yes, that is well answered. And let's move on to the discussion. And at times in clinical practice, we are struck with people who have very severe osteoporosis. My orthopedic colleagues here would say, "Can I operate on this? This bone is just going to take the nail through and through." And sometimes it's so severe osteoporosis. So, in your practice, Dr. Vinay, do you combine osteoporotic treatment? So, is it okay to join denosumab with another anti-osteoporotic agent? Definitely, calcium, vitamin D is important. But what is your take on that?
Yeah, so again, Dr. Kapoor, I take this decision based on patients, obviously clinical picture and, the age and obviously the BMD or DEXA scan report. I would say that as a first line treatment and the kind of affordability now denosumab offers and the kind of, ease of availability is there, I would start with anti-resorptive treatment as a first line when the DEXA scan score is around 2.5. But as you said, when severe osteoporosis or patient who has had a fragility fracture and we see that there is a severe osteoporosis also, I generally choose to have a combination of an anabolic and a catabolic, anti-catabolic thing. So I would combine, a recombinant, uh, parathyroid hormone treatment that is teriparatide, along with denosumab. That because that's the only combination which combines the anabolic and a anti-catabolic thing. Sometimes I combine denosumab with in females with estrogen. Some because they have other symptoms also like hot flushes and hormonal symptoms. So I choose to start them with in consultation with gynae colleagues along or medicine colleagues. So with redoxifene or selective estrogen receptor modulators plus denosumab. So that controls the hormonal part as well as the anti-resorptive effect of denosumab is there. So yes, I do combine drugs based on clinical picture and DEXA scan reports.
Absolutely. And another way in my practice, the way I would combine these drugs would be more not direct combination, but as a sequential drug. After using PTH, when I've completed 1.5 to 2 years, I would move on to an anti-resorptive drug. And I still see that though the T scores have from -4 reached -3, I would still want it to get better. And that's another very good sequential therapy that I find very effective in my practice. First, teriparatide for 2 years, followed by denosumab long term, and that really improves the BMD. It keeps the BMD that had improved with the PTH therapy, but also improves it further much more than bisphosphonates. So yes, we can combine drugs, depends on patients. Again, something that I would like to highlight here is that we have to make sure that these patients are on calcium and vitamin D supplements all throughout. It's just like putting bricks but no cement, then that's not going to help. So you have to make sure that your patients do take the recommended daily allowance of calcium and vitamin D. I would again emphasize here the recommended daily allowance for calcium for postmenopausal women in India is 1.2 grams per day, which is, if you're thinking from diet, we'll have to drink 1.2 liters of milk per day, which is not possible. And therefore, you need to have good calcium in the diet, but also calcium supplements in the form of tablet. Vitamin D at least 1,000 to 2,000 units per day is helpful. This has to be continued while we are treating osteoporosis with these anti-osteoporotic drugs. So yes, this combination does help. And the next question that I would take here is the impact of these medicines in terms of quality of life. We've spoken about the improvement in terms of the DEXA scans. Yes, you did mention that some of your patients do come back very happy and they are able to do their day-to-day activities. But again, either from literature or your own experience, what would you say is the quality of life of these patients after being started on denosumab?
So, yes, in terms of symptoms, you see, I mean, when the pain goes, I mean, most of the orthopedic practice revolves around pain. So we are pain, our practice, whether it's fracture or it's a joint replacement or whatever, is about pain, solving the problem of pain. As I said, most people sometimes come with vague pains, and especially females, and and this is quite bothering actually. Their life, their self-esteem is quite affected. They can't do activity. They have pain in walking, and everything, and that is bone pain. So yes, when the pain goes, though it's not an immediate effect. The effect is a bit prolonged. The pain when the pain goes, they are happy. Their life quality improves, and as I said, the long-term safety of denosumab is quite good. So I won't say that I have not encountered many patients who have come back to me who have said that they have had a very significant side effect with denosumab or other anti-osteoporotic medications, and then that was reason to stop it. So I would say that yes, the quality of life does improve, and it's important that we start them at the right time.
Great. So I think there are a lot of questions there that are coming in the chat box. But before we move on to that, cautious of the time that we are running into, Dr. Vinay, one last question from my side before we take the audience questions, and that's on future directions. We have a lot of research on denosumab, but what do you think is the future of this drug in terms of newer indications, in terms of newer data that is coming up? And this drug is rapidly being studied in different studies. So what would be your thought on that?
So as of now, you see, denosumab when it was introduced in the world, it was mainly for the giant cell tumor. It was mainly for malignancies, and that was the initial indication of denosumab, the monoclonal antibody, and for cancer patients. And that initially it was not licensed for osteoporosis, but then in 2010 with the freedom trial and everything, US FDA approved it for for this post menopause osteoporosis. So indications you see keep on evolving. Studies obviously help us. That's how literature grows. In my clinical practice, I would say that I've realized that it's just not about osteoporosis. Sometimes we just have pains, and even in younger patients, though DEXA scan is there, but there are still like bone turnover marker you mentioned. Sometimes bone turnover markers are high and DEXA scan is normal. So we need to have that broad vision of things. That if patient has pains and we cannot find a reason for those pains, think of something happening with bone turnover. Even if DEXA scan or bone mineral density test is normal, but that doesn't always stop you from thinking more in terms of bone turnover defect. Second role of DEXA scan, I would say, will be in my practice would be an avian, avascular necrosis of hip. It happens in young people, and there was a data from certain studies when bisphosphonates were used, and they have showed a remarkable improvement in avian rates. So avian has no cure. So I think denosumab has a role there. I have given to some people also. I've started giving denosumab along with bisphosphonates to my patients who have avian, and I've seen that there's still the data. I don't have any long term data for that or not a number of patients who consider it, but I've seen anecdotally that giving anti-osteoporotic medications in avian patients does help in recovery, does help in healing of avian, especially stage 1 and 2, and people do improve. And a third role in future would be in athletes, high performance athletes. High performance athletes have a very high demand on their bones for various reasons, like sprinters or javelin throwers or whatever. And the kind of demand on the bone does involve something which grows the bone more or helps in less bone dissolution. So I think denosumab could have a role there also. So that would be my future directions.
So thank you for sharing all those probably off-label indications. But as you mentioned, for avian, we don't have any other option. And then it's always wise to take a patient's consent that we can tell them that, yes, this is not officially indicated, but this is a possibility. And we do see improvement, and similar anti-resorptors have shown improvement in the past. So yes, after taking a due consent with the patient for your own biomedical safety, I would say it is possible to use for these off-label conditions. But I think another point that really came up from your answer is, as you mentioned, that giant cell tumor was one of the early indications for this drug, and this is in stark contrast with the use of teriparatide. And I see a lot of questions in the chat box around that. I think one point that I'd really like to highlight is being an anabolic agent, teriparatide or PTH should not or never be used in patients with past malignancy, in stark contrast with denosumab, where we are using this for a giant cell tumor. So I think this message should be there within the patient. So if you are dealing with osteoporosis in a patient who's being treated for cancer, you cannot use PTH but denosumab would be still an effective option. So I think that's great, and thank you, Dr. Vinay, for answering all my questions. I am still conscious of time. I don't know how we just quickly spent 45 minutes so fast, and there are still a lot of audience questions to answer. And before I summarize what we've really heard from Dr. Vinay, I think let's take up a few of the audience questions that have come in. And there are questions in terms of Alzheimer's and Parkinsonism, all diseases that happen in the elderly, and so does osteoporosis. So, is denosumab helpful for any of these ailments with neurological disorders? Overall, data is still to emerge for us to say anything strong. But Dr. Vinay, any comment on that from your side?
So obviously, I am not dealing with Alzheimer's and Parkinson's in my clinical practice. I would not be commenting too much on that. But yes, I don't see any harm, because obviously these patients have lack of lot of self neglect. They are very poor eaters generally, and they are obviously they are elderly and they are more likely to have osteoporosis. So I don't see any contraindication in terms of usage of denosumab as as in prevention of osteoporosis. But again, I would leave it to my neurologist and my medicine colleagues to to be more precise on that.
And maybe another point is that these patients, as you said, are bedridden, so their vitamin D exposure is also very low. And if you are using denosumab in them, you should make sure that you replace adequate amount of vitamin D before you start denosumab. Dr. Malikarjun is asking about do we need to augment denosumab and with anabolic agents? You've already addressed that with vitamin D supplements, and this he's asking again. So in osteoporotic lumbar vertebral fracture, would you sometimes augment denosumab and teriparatide together? I think you've answered it as yes. Would you like to add anything more to that?
Again, as I said, osteoporotic fracture is indication for me to start anti-osteoporotic treatment regardless of DEXA scan. And if DEXA scan, but yes, I would do a DEXA scan, as Dr. Kapoor rightly said that it's a baseline investigation. We want to monitor that. And if there is an osteoporotic fracture and DEXA scan shows a T-score off the roof, like 3, 3.54, then yes, I would go for a combination of anabolic medication plus denosumab.
Perfect. And Dr. Ashok Agarwal is asking again, when you use denosumab for spinal fractures, how long do you give in your clinical practice? You did mention, but how would you answer that question? How long would you like to give?
So in terms of treatment, when once I start denosumab, the minimum is 2 years. But as Dr. Kapoor rightly said that now studies have come up that up to 10-year efficacy and safety record is there. I have not given anyone more than 3 years. I would say I've not tried that long treatment denosumab. But yes, once I stop denosumab, I do start them on some anti-osteoporotic medications, whether bisphosphonates or whether teriparatide or something, because it has been shown that once you stop the anti-osteoporotic treatment, the bone density starts falling again. So they need something for a long time.
I think that's a very, very important message. You never stop it abruptly. Follow it up with another antiresorptive. In my experience, I would have used for many patients 6 to 7 years as well, and they're doing well. And data is there to support that you can use it for 10 years as well. Dr. Malikarjun is again raising another important point, and we did talk of postmenopausal osteoporosis, but secondary osteoporosis is also a big problem, especially for our colleagues practicing in the rheumatology domain. And with a patient with rheumatoid arthritis, when they also have poor bones, they are also on steroids at some time. That adds on to the misery of the bone. And if they have a fracture, is it safe to use in patients with rheumatoid arthritis?
Yes, so I mean, in terms of safety record, I know I don't see any contraindication in usage with people with arthritis or people who have steroids. But yes, it's a very challenging problem. People who have secondary osteoporosis, because steroids are known to cause osteoporosis. So these people who don't do really that well, like compared to primary osteoporosis. So people who have steroid-induced osteoporosis or secondary osteoporosis, I think there is a strong likelihood that you might need to supplement them with a combination of drugs, whether two antiresorptives or one antiresorptive anabolic, depending on the DEXA scan scoring and your response rate and those sort of things. And obviously, steroid stoppage is a thing, but again, you can't just stop steroids if it is indicated, in that particular clinical scenario.
Correct, but as we are seeing more and more, these monoclonal antibodies coming in, I think in my practice also I'm seeing less steroids now from rheumatology colleagues. And also, if we are seeing steroids, they're the less toxic ones, like deflazacort instead of using dexamethasone and prednisolone, which was the case before. So yes, it is definitely safe, Dr. Malikarjun. You can use uh, easily denosumab in patients with rheumatoid arthritis. Krishna Agarwal is asking if the patient has not come for the second dose, what do you do? Sometimes in practice, patient has taken the first dose in January, they're due for their next dose in July, but patient comes up in September. What would you do in that case, Dr. Vinay?
Yes, compliance is a problem, especially in a Indian scenario. In our practice, I normally don't give denosumab in my, it's not like we call them to clinic or hospital. We just contact the manufacturer, the company people, the pharmaceutical people. They deliver to their home. So I would say that in this case, the manufacturer and the company people, they ensure compliance. They would call them, they would visit their home, and if they give the right address, so I've not seen any such problem in my practice that people have not taken, because the manufacturer calls them by that time and they go to the address and deliver. But yes, just in case that it is indeed a case that someone has missed a few months dose, then again I think you just carry on with the second dose. There's no reason to stop it.
Correct. So you can give it at that time. Adding to the point of compliance, I think there's a very big initiative by the Indian Society of Bone and Mineral Research in collaboration with the Indian Orthopedic Society for something what we call as the Fracture Liaison Service (FLS), where we are trying to establish a system in which all the patients who've come to the hospital, either to the orthopedics or to endocrinology with a fracture, these patients are followed up through the hospital through this service called the fracturalization service, where they make sure that these patients are reminded of their second dose, the following dose. And I think that's a very big initiative. It's been very successful in the West, and now at this point we are doing it in 4 centers in India. And this is something that together both the Orthopedic Society and the Endocrinology Indian Society of Bone and Mineral Research has taken up in a very big way. So yes, it is important to maintain compliance, and that's helpful. So sometimes again, patients, Dr. Ashok Agarwal is asking that patients cannot afford the drug. So is it okay after taking denosumab for a while? Can we switch over to bisphosphonates or any other anti-resorptive therapy?
Yes, affordability was an issue. I would say was because there was the cost was it used to be very high for denosumab. I mean, just probably COVID time and even a couple of years back. But now the newer molecules have come up, newer pharmaceutical once it has come off patent, so now the cost has come down. It is, I won't say it's not affordable now, because the cost of 6 months treatment denosumab is, I think, almost would be as equal to going for a weekly dose of alendronate or a risodonate, something like that. That is one point. Yes, but if supposedly affordability is indeed an issue, and you people be really pedantic about it, that you don't want to spend a penny more than what bisphosphonates you spend for, then yes, bisphosphonates are a viable option. I don't think any, they are time tested and they can be continued in place of denosumab.
Perfect. And I think the last question from the audience is by Dr. Aditya Lamba, who's talking about BMD in type 2 diabetes and how, bisphosphonates, denosumab affects the BMD of a diabetic patient. Maybe I could take that. So, yes, very rightly asked Dr. Aditya, diabetes is a big risk factor for poor bone health. And the irony is that patients with diabetes will develop fracture even at not so bad BMD. So BMD can be falsely high in people with diabetes because of several mechanisms, right, from glycated A1C to the cytokines. I'll not go into the details, but what can happen, or what you can do, and what is recommended both by the Indian Society of Bone and Mineral Research guidelines and the American Bone and Mineral Research guidelines, is that you use trabecular bone score, bone microarchitecture, for assessment of bone health in diabetes. This is done through the DEXA machine, the same machine that we use, and just an additional software, but that tells us the bone quality much more. But if you're asking me whether the efficacy of denosumab would be different in a patient with diabetes as compared to somebody who doesn't have diabetes, the answer is no. The efficacy has been shown to be similar. You can safely use denosumab in patients with type 2 diabetes as well. So don't worry on that. And for monitoring, maybe bone microarchitecture is helpful. The two last questions which just sneaked in as the last minute, and I aware that we just have a couple of minutes to close. Dr. S.K. Verma is asking, role of denosumab in bone metastasis due to cancer? What should be the dose schedule, Dr. Vinay?
So initially, denosumab was indeed licensed for cancers, as we discussed at UGCT. In a bone metastasis patient, I would go for a 120 mcg denosumab, personally speaking, because the bone metastasis is quite toxic to bones, and there's a lot of bone turnover because of neoplastic syndrome. So yes, indeed, I would start the denosumab on a bone neoplastic on a patient with neoplasm or a metastatic cancer for whatever reason, and the dose would be 120 mcg, but the schedule would be the same, six monthly, and that would be my call on it. But again, I would consult my oncologist colleague on that.
Yeah, and sometimes you can, also give it more frequently. Life expectancy of these patients is sometimes not much, and so we're not really be giving a very high cumulative dose. And if the bone metastasis is a big problem, I think keeping the patient comfortable, reducing the pain. Sometimes we do end up giving much earlier also instead of 6 months. And Dr. Bharat is asking, is it safe in old age with multiple comorbidities? I think over and over again. This is a message that has been emphasized during the webinar. I completely agree. Yes, it is safe in old age. Osteoporosis is a disease of old age, and with old age comes several comorbidities. So the answer is probably yes from my side. And Dr. Vinay, anything more to
Yes,
add to that?
yes, of course, I do agree with that. Yeah, say.
Great. So I think with this, we've had an exciting 54 minutes. And that we've really completed in a very short time, I feel. There were a lot of questions. Thank you, audience, for asking all those questions. Maybe a quick 2 to 3 minute summary of what we really learned out of this webinar. We started with discussing about the mechanism of action of denosumab, how it is an anti-resorptive drug. We saw how it is placed in the bigger treatment armamentarium of osteoporosis between anti-resorptives and anabolic. This is one of the potent drugs that we have in the market. We discussed about the key efficacy, and again, it is very helpful for vertebral fractures, as Dr. Vinay mentioned. The relative risk reduction for vertebral fracture risk reduction is 60 to 70%. So very, very effective. Some effect on the fracture, less effect on the other peripheral fractures. Long-term safety, again, we have data for up to 10 years. Patients do ask about side effects. Apart from minor side effects of the injection side, we did talk about the rare side effects of osteonecrosis of the jaw, but that's really, really rare. Rebound fractures is something that you have to be aware of. So never stop this drug abruptly. Follow it up with another antiresorptive so that you can prevent rebound fractures. Overall, whether this drug is helpful in terms of fracture prevention in orthopedic rehabilitation, more data is required. There is emerging data on this field, but again, the important point that we learned was that yes, you can start denosumab even if there is just a fragility fracture, irrespective of the DEXA scan, and it is important to follow up the patient with the scans to see the improvement. You can also use bone turnover markers. Real life experience, both Dr. Vinay and I would agree that patients do come back very happy. The pain goes away, their quality of life is good, they're really happy. And it's hard at that age with bony pains to make a patient happy. So I think this drug is doing real wonders. It does improve the quality of life. And talking about future, we did talk about some off-label indications which may become in label in due course, but till that time, it is good to take patients' consent for these. One of the prominent ones would be in patients with avascular necrosis of the femur. So I think with this, we come to an end. And thank you, Dr. Vinay, for patiently answering all the questions, both from my side and from the audience. And I think this was a real treat for everybody who's been listening to us. And with this, I think I would conclude the webinar. Thank you so much, Dr. Vinay.
Thank you.
Thank you, sir.